And with sex and love addiction, what we see is that people with that history of chronic trauma, insecure attachment styles, so for them, sex or love is a great outlet because they can get some attachment needs met without the intimacy.
Compulsive sexual behavior disorder is now recognized as a legitimate diagnosis by the World Health Organization, even though it is stigmatized. Today, we speak with Dr. Stefanie Carnes about why it is important for therapists to have guidelines to distinguish healthy sexuality from problematic compulsivity. My name is Dominic Lawson. Let's go beyond theory.
Dr. Stefanie Carnes, thank you so much for coming on back to Beyond Theory, actually. How are you?
I'm well, thank you, Dominic. How are you?
I am well. So obviously we're here in Vegas for the Traumas and Addictions Conference, and you just wrapped up your session just now. You want to talk about that a little bit?
Sure. We were talking about compulsive and addictive sexual behavior, and we talked a little bit about the history of the diagnosis, some of the controversy about it not being in the DSM, some of the reasons why it hasn't been put in the DSM, and the World Health Organization's new decision to put it in the ICD-11, which is the International Classification of Diseases, which they finally did in January 2020. So we actually do have a diagnosis according to the World Health Organization. So that's very exciting. That goes a long way in terms of legitimizing the sexual addiction and sexual compulsivity as an illness. So that is wonderful. And then we talked about some of the new research, some of the neuroscience research. We talked about complex trauma and attachment, the prevalence rates, and some of the new physiological research. So yes, that was great.
Absolutely. And, I wonder if, because sex is seen as pleasurable, is that part of the reason why it's been kind of some hesitation to add it to the DSM?
Yeah, well, one of the biggest concerns has been not wanting to over-pathologize healthy sexual behavior.
Of course.
A travesty of the DSM was at one point they had homosexuality.
Correct.
As a diagnosis. And that's a big black mark on the DSM, and everybody, I think learned a big lesson from that. And so people really don't want to pathologize healthy sexual behavior. But all the more reason, in my opinion, to actually have diagnostic criteria. So therapists have good guideposts that it's only when you have impaired control and distress and unmanageability, and the client is continuing their behavior despite consequences, and their life is starting to fall apart. That's when they should have a diagnosis, not just because they're enjoying healthy, fun sex. So, yeah.
You mentioned complex trauma. Could you define that for us? I think we did that on another collaboration on Recovery Replay, but could you talk about the complex trauma piece about?
So one of the things that the research really shows is that individuals with compulsive or addictive sexual behavior have very high rates of trauma, in particular emotional abuse and neglect and sexual trauma. And so when you have high rates of trauma, you see a lot of, toxic shame and difficulties with relationships and troubles regulating your affect, those types of things that we see very commonly with compulsive and addictive sexual behavior. So with complex trauma, basically what it is you have a history of trauma that is many different episodes, including repetitive instances throughout the course of childhood, and typically it goes on into adulthood. So it's trauma that is experienced across the lifespan. So it's many instances of trauma, both big T traumas and little t traumas, right? Which are sometimes minimized, but shouldn't be, right? And so when you have that long history of trauma, that really sets the client up for additional symptoms of PTSD, not just the traditional, re-experiencing and intrusive thoughts and avoiding the reminders and the triggers that you have that are common with PTSD, but you also have affect dysregulation, relationship disturbance. You start looking for ways to self-medicate. So you end up having a history of oftentimes addictions or eating disorders, and also difficulties in relationship. And we see this at very high levels with our population, with people struggling with compulsive sexual behavior disorder or sex and porn addiction.
With compulsive sexual behavior disorder and small T traumas, because I know big T traumas is like the sexual assaults, things of that nature. What does the small T trauma in that space looks like?
Yeah, absolutely. So, so just as a few examples of small T traumas. So, like for example, bullying. Right? Most people, they experience bullying at some point during their childhood, and it's distressing, it's awful, but kids usually maybe have that happen once or twice, and they manage to bounce back from that. But if you are chronically bullied, that's a whole nother thing, right? If you have ongoing instances of bullying, that actually adds up to being a very significant trauma. So little t traumas that are cumulative can actually be as severe traumatic events as the big T trauma can. Another example, let's take like emotional neglect. So let's say, for example, I am a child at childcare and my parent doesn't come and pick me up, right? So all kids have that kind of experience from time to time. Maybe the parent is stuck in traffic or something happens. But let's say I'm always the last little kid at childcare. I'm always being forgotten. My parents are never there for me. I'm not getting the nurturing and the love that I need. Those are the little t traumas that accumulate. And so if you have a history of those kind of events that are ongoing, it makes a very significant trauma. So sometimes we have clients coming into treatment thinking, I don't have trauma. And then we start to hear their history and we're like, wait a minute here. Let's rethink that because it's minimized. Those kinds of things are really minimized and they shouldn't be because it sets the client up for things like attachment issues. So like, for example, a child that is being neglected, they don't feel loved, they don't go to their parents when they're distressed. When we are distressed as a child and we go to our parents, the parent calms us down. We learn how to regulate through our parents. We learn how to use other people and attachment to feel better. So kids that are growing up in a complex trauma environment like that, they get into a situation where they're like, I can't trust anybody. People aren't going to be there for me. And they do this thing. Right? I want connection on some fundamental level, but no, I have to deal with this all myself. And all of those little traumatic events that they have, all of those are messages to them, like the bullying, the emotional abuse, the sexual abuse, whatever it is, they feel less than, right? That they're not worthwhile or there's something wrong with me. And a child internalizes that and starts to believe that about themselves. And then they have chronic self-criticism, self-loathing, and self-destructive behaviors because surely they're not worth anything. So, and so it just creates a whole host of problems. And with sex and love addiction, what we see is that people with that history of chronic trauma, insecure attachment styles, so for them, sex or love is a great outlet because they can get some attachment needs met without the intimacy, right? So if I'm using porn or if I'm engaging in hookups, I'm getting some of those needs met without having to really let anybody in. Nobody gets to know me because, I can keep my defenses in place. And this is normal. There's, trauma survivors, this is a normal response to trauma, right? So this isn't a pathological reaction that they're having. They learned this. Of course, they don't trust people. People haven't been there for them. People have been unreliable. So it's a logical assessment for them. So, a lot of their behaviors are adaptive behaviors that they had to learn to get by with the situation that they were put in.
You're in the room with many therapists, clinicians today. What were some of those key takeaways you wanted them to take from your talk today
Well,
as they go back to their clients and things like that? Yeah.
Yeah. So one of the first things is that this is a real and legitimate issue. First of all, because of all the confusion around the DSM and the diagnosis, these clients get dismissed, they get overlooked, they're not assessed for. There's not training for them in mental health training programs. All the training programs that therapists go to, they don't teach about this in those programs. And so I wanted them to get some general information and also know that this is a real legitimate issue. So that's one key point. The other thing that I hope I emphasized is women. Women are often overlooked, and this is not just a man's issue. If you look at prevalence rates, right now, some of the most recent national prevalence data is 10% of men and 7% of women struggle with this. That's huge. That's a huge number of the population that is struggling with this, and we don't have a diagnosis, and therapists aren't being trained, right? So just recognizing that, and not only that, but it's across the board. It's across ethnicities, it's across cultures, it's across orientations, socioeconomic status, genders. So I think those are some of the key points that I wanted to convey.
I want to switch gears here a little bit because another topic I wanted to discuss with you was sexual anorexia. Janet Bentley, who's an alum here at the Meadows, wanted to talk about this subject because it was something important to her. I guess I just want to start off with, what is sexual anorexia? It would just start there.
Yeah, that's a great question. So the term sexual anorexia is actually a term that Pat coined. Okay. So he has a book called Sexual Anorexia. So, and he talks a lot in that book about the different causes, and actually a lot of that book is about healthy sexuality. But it is, if we were to look at the DSM, a lot of people would call that sexual aversion, right? And it can have a lot of causes. The main cause, I would say, is trauma. And so when people experience trauma and have trauma in the arena of sexuality, when they have sexual trauma, one of the things that happens is when they are stimulated sexually, it is a trauma trigger. So when one is activated, the other is activated. And so because the PTSD is there, there's that avoidance reaction. It's like, oh my gosh, like it can feel very overwhelming. And they can also experience a lot of shame as part of that, which shame is it can be an excruciating emotion for people. And so when the trauma is triggered, that the shame around the abuse comes up, which shuts a lot of people down. People have a lot of different defenses for shame. And one of the things that we really try and emphasize to people that have trauma, that shame is what we call carried shame, that it's not their shame, it's the perpetrator's shame. That they did nothing wrong. They didn't deserve what happened. There wasn't anything that they did that caused that. It was no fault of theirs, because trauma survivors think that a lot. They think, oh, if I hadn't have done this, or if I hadn't done X, Y, Z, this wouldn't have happened. They'll blame themselves. But there's nothing that they did that caused that. The shame is actually carried from the perpetrator.
Right. It's interesting you say that, because I have two daughters, mm-hmm. and they go to school, and I think about some of the clothing regulations particularly for girls, like tight leggings and stuff like that. And there should be some rules or whatever. But when you were talking about that shame piece, I often think about how there's sexual assault victims and they say, oh, it was because of what you were wearing, or it was because of you were at this club, or you were at that part. So when you were talking about that, that's what came up for me just now.
That's a great example of blaming the victim in the situation. In our culture, girls are very much expected to dress in oftentimes a hypersexualized way, and to, there's a woman named Gail Dines who talks a lot about the effect of like pornography on young girls, and one of the things that she talks about is she says that girls can either kind of accept those parameters and dress sexy and look like sexy, or be invisible. And for teenagers, being invisible is not an option, right? And it's not just for teenagers, but for women in general. There's so much around body image and beauty standards, and we have to be hairless and thin and all certain ways, and all of very unrealistic, oftentimes unattainable goals for women. And it creates a lot of shame, body shame, and body image issues for women of all ages, really.
Absolutely. One more question about sexual anorexia, and I guess kind of related to the shame piece, like a married couple or something like that, right? I imagine that can be some issues there, right? Like if you are the partner you're the partner who has the partner who's probably struggling with that, what are some of those things that partner can do to kind of help support what they're going through? Because I imagine partner like, oh, we're not having sex, what's up with that? What are some examples of what they could do to kind of support that?
Yeah, absolutely. So one thing I would also say, just on the topic,
Sure,
is that it's not always trauma, right? It could also be around attachment, which is in some ways trauma too. But if they never had that secure attachment or had difficulties with attachment, that can create issues in the coupleship, right? So again, they may be doing this thing again with their partner, right? And so that is very painful for the other party, because they don't know what's going on, and they don't understand what some of what the root causes are of that. And there can be lots of reasons why a couple may be disconnecting in that area. Lots of different reasons. One of the first things to do is to get a medical evaluation first and foremost, because there are many, many medical conditions that can cause like a inability to become aroused, for example. So things like depression certainly can, diabetes can, medication side effects can. You can have there's all sorts of health conditions that can cause that. So the first step is rule that out. The second step is couples therapy, because also there can be dynamics within the couple that can be fostering closeness or distance in the relationship. So sometimes when there's miscommunication, or the partner is inadvertently triggering maybe pain or past trauma, it can cause the other party to distance. And so there could be some dynamic that is a result of the relationship. So you have that. Another thing that can be an issue is addiction. If they are actively in an addiction, that can interfere. So sex addiction is a perfect example of that. If they are going outside of the relationship, that can create obviously disconnection. If they're using a lot of pornography, you can actually have sexual dysfunction in the relationship. So when you have somebody that is like using extensive pornography and they've got all of this intense stimuli coming at them, novelty, all these new images and new things to be aroused by, and then you get in bed with your same partner that you've been with for 10 years, it's hard for your partner to compete with that, right? So one of the things that I would recommend for any couple that's dealing with this is really getting a comprehensive assessment to figure out what are the root causes of what's underneath all of that. Is it trauma? Is it something medical? Is there a dynamic here? Is there an addiction here? Because we want to make sure we're getting to the right issue.
Of course, of course. You made me think of our episode with Recovery Replay with Nicole Andrea. She talked about her partner or boyfriend at the time where he was watching a lot of pornography, and there was no connection there. It was almost more like she was just like a slate to act out on or something like that. Right, so that reminded me of that when you were talking about that just now.
Yeah, sometimes as an addiction develops, part of what can happen is fantasy and objectification can be such a big part of that, and a lot of that is up here, right? So they can be engaging in that behavior, which can decrease the sex drive, but they can also be engaging in a lot of fantasy and objectification, which is not going to help that connection or that intimacy grow.
Of course, of course. Dr. Carnes, thank you so much for coming on Beyond Theory. Just any last takeaways you want for our audience to kind of have for this episode?
Well, one thing I would say is that for people to keep in mind that both for sexual anorexia or for compulsive or addictive behavior, these are things that are very treatable, and recovery is possible, and to not lose hope.
Beyond Theory, powered by Meadows Behavioral Healthcare, is produced and hosted by me, Dominic Lawson. The film recording of this episode was created by our videographers, Haley Storer and Jesse Adelman. You can watch it at beyondtheorypodcast.com. Special thanks to Dr. Stefanie Carnes, Senior Fellow here at Meadows Behavioral Healthcare and Clinical Architect of Willow House. Find out more about her work at www.willowhouseforwomen.com. Be sure to like, review, and subscribe to the Beyond Theory podcast on Apple Podcasts, Spotify, or wherever you listen to podcasts. And if you think someone could benefit from these stories, please share it with a friend, neighbor, or loved one. Finally, thank you for listening, and I hope you join us next time for another episode of Beyond Theory.